एस्थमा एक ऐसी बीमारी है जिसको समझना बहुत ज़रूरी है। अगर सुलझ जाए तो आसानी है, अगर उलझ जाए तो मौत की सवारी है। So today we will simply discuss asthma. So before going to the in details of the asthma, we will briefly know that what is the epidemiology of asthma. Now in the epidemiology we will see that in the adults 10 to 12% of the adults are affected by the asthma and 15% of the children are affected by the asthma. A very interesting allergen, that is house dust mite, named Dermatophagoid terroricinus. The name will appear here or here. So, and one more thing, if you get a patient with asthma and the asthma is severe, that means that the asthma was severe from the beginning, and if you get a patient with mild asthma, that means that asthma was mild from the beginning, right? Now go to the risk factor and the triggers. Now what are the risk factors? Risk factor means some factors which are, if they are present in a person, a disease have a more chance to occur in that person. A trigger means those factors which create the symptoms or which make the symptoms arise in a person in whom the disease is present, right? Now at first the risk factor, the main risk factor for the asthma is atopy. So before going to the risk factor, I want to clear one thing, that there are two types of asthma grossly, that is extrinsic asthma and another thing is the intrinsic asthma. In the extrinsic asthma you will get these allergens or these risk factors, triggers, but in the intrinsic asthma you will not get any type of allergens or triggers or risk factors, because these intrinsic asthmas don't give any type of the skin test positive for any allergen. These intrinsic asthmas don't have high plasma IgE level, right? And one more thing, that is if you see locally, that is in the airway, in the intrinsic asthma there is high level of the IgE present. Okay, done in case of intrinsic. Now come to the extrinsic asthma. For the extrinsic asthma, the risk factors are atopy. If a patient comes with asthma, that means there is a probability, there is a higher chance of having atopic dermatitis. Actually, these allergens causes sensitization of the patient, that is increase IgE production in the body, in the plasma, and increase inflammatory reactions. Next, genetic predisposition. Generally the chromosome number 5q, that is the long arm of the chromosome number 5, if there is a polymorphism, then the genes that those are required for the interleukin productions by the T helper 2 lymphocytes are mainly present on this 5q. After polymorphism, they will cause more production of the interleukins, and like interleukin 4, interleukin 5, interleukin 9, interleukin 13. These are associated with the atopy also. Next, we get three interesting genes: ADAM33, DPP10 and ORMDL3. You will get the names of these genes here or here. And one more thing in the genetic predisposition, if a patient with asthma have arginine glycine 16 sequence in the beta 2 receptor, the beta 2 agonist that we use for the treatment of the asthma, like short acting beta 2 agonist or the long acting beta 2 agonist, will have decreased response. And if there is a presence of SP1 recognition sequence in the lipoxygenase, then the antileukotrienes will have decreased response. After the genetic predisposition, we have some infections. In the infections, we get viral infections like respiratory syncytial virus. Second, adenoviral infections. Some atypical mycobacteria also cause infections and create asthma or create this hypersensitivity. That is the Mycoplasma and Chlamydophila. Then after that we get some other factors, other risk factors. Those are not very important. The important one is the obesity, because a obese person create more amount of the pro-inflammatory adipokine and decrease amount of the anti-inflammatory adipokine. So there is higher chance of inflammation. Next we get more intake of paracetamol, that is acetaminophen. The paracetamol, if a children in the childhood age, if a person get more amount of paracetamol or acetaminophen, due to oxidative stress, it is seen that there is a higher chance of asthma association in the later life. Okay, after the risk factors we get the triggers. These allergens, air pollution, exposure to the dust, these are actually the triggers of asthma, right? But the most important trigger is the exercise, for the exercise induced asthma. After that we get the pathophysiology. In the pathophysiology, at first we have to know the pathology. To know the pathology, we have to get a specimen from the airway. We can get that from a dead person or from a person who is alive by the bronchial biopsy. In that specimen, if we see the airway, in the airway specimen, if we see under microscope, we will see that there are there are increased number of eosinophil, mast cell, T lymphocyte, and these are actually activated. Activated eosinophil will produce fibrogenic mediator like TGF beta, right? Fibrogenic growth factor like TGF beta. This TGF, due to the action of this TGF beta, there will be deposition of collagen 4 and 5 in the sub-epithelial region and thickening of the basement membrane, which is a feature of wall thickening in the asthma. After this we get interesting vascular feature, that is increased vascularity, and that is increased vasodilation and angiogenesis. So due to this vasodilation, there is increased amount of the leakage, and this will cause edema. Along with this leakage, there is more amount of the plasma protein that comes, and you know that the lining of the airway tract, there is goblet cells. These goblet cells secrete what? Mucus that contains glycoprotein. So there is formation of mucus plug. So what are the component of mucus plug? One is glycoprotein, which comes from the goblet cells, and the plasma proteins that comes from the leakage of the vasodilation. There is one more feature, that is angiogenesis. This angiogenesis mainly occurs due to vascular endothelial growth factor, VEGF. Okay, after that we will see another, and this mucus plug makes this asthma more fatal. And another thing is there which makes the asthma fatal, that is the shedding of the airway mucosa cell. That shaded cells comes and get together in the lumen, and the wall of the lumen gets thickened due to edema and bronchoconstriction. So there is a narrowing of the lumen, wall thickened, edema, inflammation, bronchoconstriction. Along with that, the mucus plug is there, and the shaded mucosa or the shaded epithelial cells also present. They cause the asthma, they make the asthma more fatal. Okay, after this we will go to the cells, like inflammatory cells. The first inflammatory cell is the mast cell. This mast cell produces, after activation, produces some inflammatory mediators like histamine, and the eosinophil is also activated. This eosinophil produces fibrogenic mediator. I previously told that TGF beta, and then comes dendritic cells and macrophages. These dendritic cells are actually the antigen presenting cell or the APC cell. Due to presence of thymic stromal lymphoprotein, TSLP, this APC cells will cause conversion of the unemployed T lymphocyte into TH specific, antigen specific T lymphocyte, and there is more number of the TH2 T lymphocytes. In normal there is TH1 greater than TH2, that is TH1 is more, but here the TH2 is more. TH2 will produce interleukin 4, 5, 9, 13. Then 4 and 13 are actually associated with inflammations and other procedures, and interleukin 5 is associated with eosinophil activation. So almost all the inflammatory cells are done. After that comes inflammatory mediators or the inflammatory substances, inflammatory mediators. At first cytokine, the interleukin 4, 5, 9, 13, these are secreted by the T helper 2 lymphocyte. There is some increased amount of the pro-inflammatory cytokine like TNF alpha, interleukin 1 beta. There is some decreased amount of the anti-inflammatory cytokines like interleukin 10 and interleukin 12. After this we get a very interesting point. That is, there are some T lymphocytes which are actually regulatory, which regulate the inflammation. They actually decrease, and these regulatory T lymphocytes are actually CD4 plus and CD25 plus. And there are some innate T lymphocytes or some inner T lymphocytes which also causes the inflammatory action by interleukin most probably 25 and 33, right, and they also produces the similar action of the Th2 lymphocytes. Okay, after that we get some chemokines under the inflammatory mediators. In this chemokine, the epithelial cell will express two ligands, three ligands, actually CCL11 and CCL17 and 22. This CCL11 bind with a receptor on the CCR4 or CCR3 present on the eosinophil, and the CCL17 and 22 bind with Th2 by CCR4 receptor. So CCL11 bind with CCR4 which is present on the eosinophil, CCR3 which is present on the eosinophil, CCL17 and 22 bind with CCR4 which are present on the Th2 and causes their activation. Okay, so after this there are some other inflammatory mediators which are not much required. Then we come some nuclear factors or the nuclear factor and the genetic factors like nuclear factor Kb, activator protein 1, and some proteins which are required for the cytokine, chemokine or these inflammatory mediators, right. Okay, after this we go to the effects of inflammation. Now at which area this inflammation is mainly, or these asthmatic features of the inflammation mainly present, the area is mainly the cartilaginous bronchi, but the inflammation is present all over the bronchiole up to the terminal bronchiole, but mainly this cartilaginous bronchi is more affected, and there are some changes in the airway, that is mainly the airway hyperresponsiveness. The main causes of airway hyperresponsiveness is 4, right. First is breakdown of the barrier, and due to the breakdown of the barrier mechanism there is a more entry of the allergen. Second, there is presence of natural endopeptidase. Natural endopeptidase. That natural endopeptidase will break the peptide types of the inflammatory mediators, but these peptide types of inflammatory mediators are now increasing as the naturally occurring peptide endopeptidase are absent. Next, there is some relaxing factors are released, so there is decreased relaxing factor causes more inflammation, and there is more exposure of the sensory nerves which makes it more sensitive. Airway remodeling, there are 4 steps: mucus hyperplasia, hyperplasia of the smooth muscle, fibrosis and angiogenesis. After this, the pathology or the pathophysiology ends and we begin with the treatment. For the treatment of the asthma, we mainly use 2 types of drugs, one for the bronchodilation and another for the control of the asthma or the inflammation. For the bronchodilation, we mainly use the beta 2 agonist. There are 2 types of the beta 2 agonist. One is the short acting beta 2 agonist, another one is the long acting beta 2 agonist. And all these beta 2 agonists act by through the G protein and cause activation of the adenylate cyclase. This adenylate cyclase will produce more amount of cyclic adenosine monophosphate, right? Cyclic adenosine monophosphate. And this cyclic adenosine monophosphate causes the dilatation of the bronchodilation actually. Now, the short acting beta 2 agonists have one interesting feature, that is it creates the symptomatic relief very fast. So, these are mainly used for the symptomatic relief only, but these are not for the long term treatment, right. There are 2 interesting actually 3 interesting beta 2 agonists: salbutamol, albuterol and terbutaline, right. And the long acting beta 2 agonists, these are given up when the low dose inhalational corticosteroids are not much effect cannot control the asthma, then we give the long acting beta 2 agonists, and under which we get the salmeterol and formoterol, and one interesting product, that is indacaterol, is given once daily, right. And the side effects are decrease in the potassium concentration in the plasma. There may be some palpitation and muscle tremor along when we use the beta 2 agonists. Okay, these are mainly selective beta 2 agonists, right. After that, we get the anticholinergic drugs, but these anticholinergic drugs are not as effective as the beta 2 agonists, because the beta 2 agonists actually cause antagonism of almost all types of the bronchoconstriction mechanisms, but these anticholinergic drugs causes antagonism only against the anticholinergic bronchoconstriction mechanism. So, it is not as effective as beta 2. So, these are given after beta 2 agonists, right. After that, we get methylxanthine. In the methylxanthine, one of the important drug is the theophylline, but due to its side effects, these are not given very commonly. The theophylline mainly acts by preventing the phosphodiesterase enzyme. This phosphodiesterase enzyme causes breakdown of the CAMP, that is cyclic adenosine monophosphate. So, after preventing the phosphodiesterase enzyme, methylxanthine, the theophylline increases the amount of the CAMP. So, this CAMP will produce more amount of the bronchodilation, but there are many side effects. We have to measure the blood level of the methylxanthine or the theophylline. 5 to 10 milligram in the blood per deciliter in the blood is normal. Normal level is 5 to 10 milligram, can be tolerated. In higher or the severe asthma, we can give up to 10 to 20 milligram, but in the higher level there are some side effects. Due to phosphodiesterase inhibition action, we get one important side effect, that is nausea, vomiting, there is some nausea, vomiting, headache, palpitation. And for the adenosine A1 receptor antagonism, there is seizure, convulsions. Even in higher cases, there may be tachycardia and death may also occur. And then comes the controller therapy. In the controller therapy, we get the inhalational corticosteroid. 2 important inhalational corticosteroids are one is beclomethasone and the fluticasone. Actually I remember these two names very easily, so I remember these names. And these are given in the meter dose inhaler or nebulizer, right? Actually meter dose inhaler. These have some side effects like hoarseness of the voice, or there is oral candidiasis. So you have to give these drugs by large volumes pressure device. The mechanism of action, if we see the mechanism of action of these corticosteroids, inhalational corticosteroids, what they causes the block, the transcription is blocked, right? Transcription of some genes are blocked. The genes which are responsible for the cytokine, chemokine and adhesion molecules production, those genes are actually blocked, right? After that we get and as this process comes, okay, so in inhalational corticosteroid do two more important things. It causes attachment of the HDSC2 to the inflammatory gene complex, and this inflammatory gene complex, and there will be reversal of the histone acetylation. This is one of the, that is histone acetylation, one of the important feature of inflammation, and that is reversed due to addition of that. One more thing, it also prevents the nuclear factor Kb, which is required for the inflammation, and it also increases the beta 2 receptors, and some anti-inflammatory genes are activated, and some beta 2 receptors are increased in number. So more, so if you give beta 2 agonists, they act more precisely or more accurately. Then we get the oral corticosteroids. These are given in higher forms or the more severe forms of asthma. In the oral corticosteroid, there are many side effects, like there is cataract, diabetes, hypertension, truncal obesity and osteoporosis. So in the postmenopausal woman, you have to see the blood, the calcium level, bone condition, so that at a specific time we can give the bisphosphonate to the patients to prevent the osteoporosis. Okay, after this inhalational corticosteroid, there are some other, the oral corticosteroid, there are some other drugs like anti-Ig antibody, that is monoclonal antibody omalizumab. There is two other drugs like leukotrienes inhibitors, or anti-leukotrienes, that is montelukast, dafelukast, and the mast cell stabilizer sodium chromoglycate, neurochromyl sodium. Okay, after all these things, now we have to go to these are the mainly treatment. Now we have to know how we will diagnose the asthma. For the diagnosis of the asthma, at first we use the simple spirometry for the lung function test. In the lung function test, you will see that the forced expiratory volume will be decreased, forced expiratory capacity will be decreased. The ratio of the forced expiratory volume at 1 second to the forced expiratory capacity is also decreased with respect to a normal person. In the flow volume curve, you will see that the peak expiratory flow rate has been decreased. After this, we do the tests for the asthma. You know what type of test? That is the airway hyper responsiveness test, and that test is done in the form of methacholine or histamine challenge test. Okay, I forgot one important mediator or important mediator of the asthma or the inflammation, that is the nitric oxide. It is one of the important mediator of the asthma. Actually, it is a new approach that use of this nitric oxide. Nitric oxide is produced in the airway. I forgot to mention this in the inflammatory mediators. You have to mention it there. Actually, this nitric oxide is produced due to the action of the nitric oxide synthase. This nitric oxide synthase enzyme is produced by the epithelial cells and the macrophages. This nitric oxide actually causes the vasodilation and the bronchoconstriction to some extent, but mainly vasodilation. So, and this nitric oxide is exhaled by the patient in the exhaled air, and this nitric oxide is tested for the and we test this nitric oxide for its presence. The test is called fractional exhaled nitric oxide, FeNO, and this test is used for the prognosis of the disease and the effectiveness of the treatment, that is the treatment, how much the treatment is effective. You can also do the imaging studies. In the imaging study, you can do the X-ray of the chest or the CT or the high HSCT, that is a high resonance CT, but those are required when there is infection in the chest or there is bronchiectasis or any, but those are not required for normal asthma patients. After this, we get one interesting thing that is a treatment part, right? And we can do also the skin test. Before that, we can do also the skin test. Okay. Now we have to see the treatment part. Treatment means the drug regimen part. What are the drugs given for the chronic asthma? It is the main patients. Maximum patients will come with this, the chronic asthma. For the chronic asthma, for the mild transient asthma, the short-acting beta-2 agonists are given. For the mild persistent asthma, short-acting beta-2 agonist along with that low dose ICS, that is inhalational corticosteroid given. For moderate persistent asthma, short acting, that is SAB, SABA, along with that low dose ICS, along with that long acting beta-2 agonists are given. For the high persistent or the severe persistent asthma, we give high dose inhalational corticosteroid along with that SABA and the long acting beta-2 agonist. After that part, when the asthma is very severe, then we give the short acting beta-2 agonist, high dose of the ICS, high dose oral corticosteroid and LAB, that is long acting beta-2 agonist also. And how will we monitor the treatment? For the monitoring, there are three parts. The asthma is controlled, partially controlled and uncontrolled. If four things you have to remember, right? At first, night awakening, number of the reliefs, number of the rescue activities required for the patient, daytime symptoms, and fourth one is most important. Fourth one is the asthma makes this patient preventing, that is asthma prevent the patient from doing his activity or not. If the asthma makes the or prevents the patient from doing his activity, then that is called, that will be partially controlled and uncontrolled asthma. Now we have to know acute severe asthma. The features of the acute severe asthma are very okay. So one more thing, I forgot to mention the clinical features, right? The clinical features of the asthma. The clinical features of asthma is the classical triad of cough, wheezing, dyspnea. Actually, patient present with rhonchi. If you auscultate, then you find rhonchi all over the chest. Patient says that the symptoms get worsened at night or in the early morning, and the cough and the mucus is tenacious, so the patient cannot expectorate the mucus easily, right? After this, as these are done, now comes acute severe asthma. In the acute severe asthma, the symptoms will be more worsened. There will be chest tightness, wheezing, dyspnea, right? And this and the patient will complain that, actually you will find, not patient will complain, actually you will find that the patient has a hyperventilation, tachycardia, hyperinflation of the lung, right? So, and one more important thing, due to hyperventilation or hyperinflation, the CO2 washout, there will be low CO2, PCO2 concentration, PCO2 in the blood, and if the PCO2 is normal or high, you have to assume that there is a impending respiratory failure, right? Then you have to start the prophylactic in the endotracheal intubation. So for the treatment of the acute severe asthma, at first you have to give the oxygen, right, and the saturation should be up to 90% of the, and you have to go up to the 90% of the saturation, and then you have to give SABA, that is the short acting beta 2 agonist. If they don't work, then you have to give the IV anticholinergic agents, and then aminophylline, that is the methylxanthine IV. But you have to remember always you have to monitor the blood level, and when this does not work and you are seeing that the patient is going towards the impending respiratory failure, then you have to do the prophylactic endotracheal intubation, find out the cause, for what purpose this type of the exacerbations is occurring, and you have to solve it. Yeah, you should not give, generally the antibiotics, lots of the antibiotic you should give, but not much required. And okay, so after the discussion of the asthma, one important thing comes, that is the differential diagnosis. It is always asked for any disease, you have to know the differential diagnosis, try to know the differential diagnosis at first. So why this differential diagnosis concept came, that is the symptoms are same, but the other features are different, the cause is different. At first there is wheezing dyspnea, this may be present in blockage of the airway by some mass of the tumor. Bronchoscopy, by doing the bronchoscopy we can see the where is the mass present, and there is, and if you do the flow volume curve, there will be decrease in the inspiratory and expiratory, both the flow rates will be decreased, and there will be stridor, both cases. In asthma there is only expiratory, but here will be inspiratory and expiratory stridors both. Okay, after this there is another differential diagnosis, that is vocal cord dysfunction. Actually it is a conversational hysterical symptom, right, conversational hysterical disease. It is nothing very important, actually it is a psychological disease. Patient thinks that his voice is just like that. In the left ventricular failure you will also get this type of feature, but there will be basilar crackles, and in case of endotracheal foreign body, right, in case of endotracheal foreign body, there will be localized wheezing in a particular area of the chest, you will find a wheezing, and there may be the eosinophilic bronchitis. There is also high level of eosinophil, but some features of the asthma are not present there. COPD may present with this type of with the similar features of the asthma, but most important thing is the COPD does not improve after the application of the short acting beta 2 agonist, right. And actually with this I came to the end of the discussion of the asthma. If you like the discussion of simplified in the asthma in the simplified form, then you can subscribe you can like this video, subscribe my channel, because I think I plan to produce this type of simplified videos on these diseases regularly as the time permits me. I try to post this type of videos. So if you like this video, give this video a huge thumbs up, share this video with those friends who need to know, who require this type of videos. So share these videos with those friends and subscribe my channel for more new awesome videos, and comment down below so that I can know how you love this video, right? And bye bye.